Today we will be talking about an approach to psychiatric assessment. First of all, we should consider what is our main goal in the psychiatric assessment. In my opinion, we should be distinguishing between disease and non disease, or that is to say, clinical psychiatric disorders versus non disorders. First off, we can evaluate for mood disorders. In this case, we can separate mood disorders into the classic manic depressive illness or unipolar depression, better known as major depressive disorder in the current versions of the DSM, and bipolar disorder. In mood disorders, we will see that there are different episodes. So you could be euthymic, you could have a depressive episode, a manic episode, which is a profound sort of change in thinking and behavior, which sometimes will land the patient in a medical setting. Hypomania, which is less profound, but still can be very debilitating, and subsyndromal depression, as well as all of them or mixed episodes. Okay. In major depressive disorder, you'll see recurrent depressive episodes lasting weeks to months, and they're very characteristic. In fact, patients can be very debilitated by these mood episodes. Sometimes we'll see depressed mood in patients. However, they may be related to some sort of event in their lives. And in these cases, they may be a form of bereavement, in which case, many times medications are not indicated. In bipolar disorder, one will see both depressive episodes and either hypomanic or manic episodes. So in bipolar 2 disorder, one would see hypomanic episodes, and in bipolar 1 disorder, one would see manic episodes. It's important to note that in bipolar disorder, patients spend most of their time in the depressive phase and only a smaller amount of time in the hypomanic or manic phase. Of course, we should recall that mixed episodes can occur in which you have both manic and depressive symptoms at the same time. And that is uh, very impairing for patients. To screen for bipolar disorder, one could ask this relatively short question: have you ever had 3 days or more of decreased need for sleep, say a few hours nightly, and felt irritable and did things that you would normally not do, such as oversharing your personal life, driving too fast, or spending lots of money? We could also consider using the CD or CIDI, which is an instrument validated for detecting bipolar spectrum disorder. And this is a particularly good instrument to detect bipolar 2 disorder, which is often underrecognized and can go underrecognized for 10 years or so, where the patients may be receiving antidepressant treatment for that amount of time and not improving. So we would ask these questions here. If you get 2 out of the 3 questions, you would move on to 9 more questions. However, if the patient does not endorse 2 out of the 3 questions, you can simply stop the screening part. So it's very efficient, effective. One thing to note is that the patient cannot take the CD on their own. It needs to be administered by someone. The PHQ-9, or the Patient Health Questionnaire 9, is based on the DSM questions for major depressive disorder. And it's important to note that in order to meet criteria for depression, one should have either depressive symptoms or anhedonia. Okay. Now, the PHQ-9 does describe the severity of symptoms, which it's helpful, but it doesn't necessarily clinch a depressive disorder diagnosis. One needs to use clinical judgment in order to give that diagnosis. So Um, Now, when we administer the PHQ-9, we want to ask if the symptom is different from one's baseline. For instance, if someone is constantly tired, then if someone endorses low energy or fatigue, that is not different than how that individual usually feels. So typically, I wouldn't count that item in the PHQ-9. And of course, we want to have specific time frames for when these symptoms occur. Now, if we were to work in a hierarchy of diagnoses, first we want to rule out or rule in mood disorders. Then we want to kind of go to the next set of disorders that's quite biological, like mood disorders. So in this case, schizophrenia. And the history is usually pretty revealing. The symptoms are also very characteristic, so largely having to do with positive and negative symptoms of schizophrenia. And so manic depressive illness and schizophrenia were very well described by Emil Kraepelin. But now we can think about anxiety disorders as well. Now, these days we have generalized anxiety disorder, panic disorder, obsessive compulsive disorder, and in general, they all have their characteristic presentations. Now, substance use can mimic a lot of the symptoms of any of these mood disorders, psychiatric disorders, or anxiety disorders. So that's something that's super important, taking the substance use history. And many of these disorders and substance use can result in inattention, which is a very common presentation to psychiatrists and medical providers alike when patients are wondering if they have adult ADHD. Thank you so much for your attention.